Okay, great. All right, is everyone seeing that intro slide displaying pretty clear?
It's not on the screen.
You're not seeing anything?
No, nothing's on the screen. It was for a second, but it's not on the screen anymore. Yeah, you're good now.
All right, all good now?
Yep.
Great, okay, thanks. Yeah, so I'll jump right in. So what do we mean when we say natural history, or when we're studying natural history? So in medicine, a natural history study is a study that follows a group of people over time that have or are at risk of developing a specific medical condition or disease. And the purpose of these studies is to collect some information over time to understand the etiology of the medical condition or disease. So how does it develop? What are the risk factors? How might one prevent it? And what are the ways in which one might treat it? So here when I'm talking about natural history, I'm using the term more generally. So I'm going to be talking about some data collected using these types of longitudinal methods where you would start following individuals at a young age before they start using drugs in order to collect information prospectively, and also some studies that collect data retrospectively. So asking folks, perhaps once they've already started using or developed a substance use disorder, what were some of the precipitating events, or when did they start using at what time, et cetera. So I'm using the term a little more loosely here, rather than a pure natural history study type usage. So I think the reason why this is important too is that, and you guys might be past this and aware of others now, but there's this sort of common perception in society that I think is an oversimplification, that you've got this trajectory where experimental use of tobacco, alcohol in your teenage years directly and in that temporal order leads to use of harder drugs, to meeting criteria for a stimulant disorder for harder drugs, to things like overdose, lost jobs, homes, and then morbidity or mortality, with each step in the progression sort of being caused by the prior step, a causal gateways. And, is this true or false? I think it's both or neither. So I think a lot of that sort of popular understanding of the substance use trajectory throughout the life course represents an oversimplification of some complex relations between a lot of variables that govern behavior and within individuals during their human developmental trajectory. I mean, this is still a trajectory that occurs, but it's not the most common. It is common, but it is very salient. And I think that's the reason why it drew so much interest in pop culture, as sort of an understanding of how drug use progresses through the life course. So most of what I'm trying to get at here is not to go into too many details about all the nuts and bolts of what we know now about these different trajectories in natural history, to go over some sort of seminal studies and some important information that will sort of give you guys the gist, and also to understand what are the methods used to collect this research, what is the value from the data added, and how does one interpret it and fit it into their science. So the thing to remember with even the most basic in vitro research in drug discovery or studying cellular mechanisms of addiction, it's important that we remember that we're really doing all this controlled basic science as a way to better understand, prevent, and treat a very complex and very human condition that presents over the course of a life course. So that's the reason why I wanted to start this science-based lecture component with the natural history. So I think one real good study to highlight here that's was fairly groundbreaking at the time, was done years ago, was a study by Chen and Kendall that was published in the 90s. It's really the seminal report on natural history of legal, illegal, and medically prescribed drugs, following a cohort of teenagers from New York State public school systems from ages 15 to 16 to ages 34 to 35. And while these are some older data, so these students were followed from 1971 to 1990, the general patterns that they observed are really still relevant today, in that, the relative popularity in terms of incidence of use of particular drug classes has changed a little bit. The age in which people start to experiment or develop problematic use or age out. There have been some slight shifts, but overall what they identified is just really shown to be a fundamental pattern in the natural history of life of drug use across human life course. So what you're looking at here, I don't think I have a pointer today, but that's okay. You're looking at here in figure 1. So this is looking at a hazard rate of illicit drugs other than cannabis. So, and then for prescribed drugs. So what you're seeing here is all other illicit drugs in the dotted line and prescribed drugs in the solid line. And then you're seeing age of initiation on the horizontal axis. That's by hazard rate, it means when did it happen? So when did they start using these? And then a hazard ratio is just a metric for the proportion of hazard or initiation at that time occurring at that specific time relative to the entire time course. So basically what this figure is illustrating is that the vast majority of these individuals who used any of these drugs between young age and ages of 35 had initiated use before age 21, with the most common age being around 17. So on the right in figure 2, you're seeing a similar display of information, but this is, instead of hazard, this is current use, so current prevalence of use of a couple of major drug classes, so alcohol, tobacco, cannabis, and other illicit drugs. And what you're seeing here is that the peak prevalence, so the proportion of every users using at that current time in the past month is really highest in the mid-20s, almost across drug classes. You see a much more robust drop in cannabis as individuals enter their mid to late 20s, but you see alcohol and tobacco use hovers higher. Remember, this isn't disordered use, this is just any use. So the takeaway here is, in the general population, you get relatively high rates of substance use starting in late teenage years and being most persistent through the early 20s. And then for at least all illicit substances, it tends to start to taper off by the mid to late 20s. These second 2 sets of figures are just, again, looking at the data a little bit differently. So this is figure 3 on the left is showing the periods of highest frequency of individual use. So again, rather than just initiation of use, which was figure 1 before, or prevalence of past month use, this is the period of most intensive use. So these figures graphically depict when are folks during their life course in which they are using, at what times are they using the most, so the most frequency. And you see for most of these individuals across alcohol, cannabis, you see it's late teen years to early 20s. Cocaine tends to be a little later, in the mid 20s. And tobacco maintains relatively stable after sort of peak use hits around age 20 or 21. That's in terms of frequency of number of cigarettes smoked, right? And then on figure 4, you're seeing the proportion of daily or near daily users, daily or proportion of individuals who ever used who are using daily or near daily at that time in their life. And you're seeing the same thing. Really hitting the peak by the late teen years, and for cannabis starting to taper off in the mid-20s, for alcohol maintaining relatively stable. So, and I didn't go too much into prevalence, but these behaviors are very, very prevalent. 97% of the sample were alcohol users, right? About half had used cannabis at least once in their lifetimes. So in the general population, substance use peaks during is very prevalent, right? So it's nothing unusual, and it generally tends to peak during adolescence and early adulthood. And you tend to see this consistent maturation pattern in general for most people, for most substances. You'd call it aging out. So like I said, over time, the specific initiation and maturation patterns for individual substances have changed. For example, tobacco, the prevalence of combustible tobacco cigarette smoking has increased substantially in the last 20 years. The prevalence of marijuana has remained about the same, but the persistence has increased, meaning that now it's much more common for individuals to continue heavy cannabis use into their late 20s and early 30s, whereas 30 years ago, those folks would have generally aged out. So these are really common patterns of behavior, substance use in general. And for the majority of individuals who ever use these substances, they don't necessarily become a substance use disorder that's a significant problem. That's experimental use at a young age. But a fair proportion do develop substance use disorders. And to sort of outline what those are, so I'm just going to define some terms here that I think are interesting that get thrown around. So differentiating between substance use disorder and the term addiction that gets thrown around. So substance use disorder really falls on what is if you look at the figure on the top right, the pyramid, sort of a hierarchy of severity or intensity of substance use related problems. So the most important thing to remember is that we define substance use disorder not by the frequency of use or the intensity of use, but generally speaking by the problems said use causes in terms of significant impairment and distress in an individual's social, occupational, personal life, etc. So, but it's important to consider that there is a very, very strong relationship between frequency and intensity of use and these problems. So again, while substance use disorder is a measure of problems caused by drug use, not frequency or intensity, the more frequent or intense the substance use, the more likely individuals tend to have problems. So this is a medical or a clinical concept. And so the current diagnostic criteria in the DSM-5 or Diagnostic and Statistical Manual of Mental Disorders 5. Anyone who has, I'm going to go over the symptoms on the next page. Experiences 2 of 11 symptoms, core symptoms across different substances of abuse. So there's 10 different drug categories that are specified. So you can have a nicotine use disorder or a cocaine use disorder or a cannabis use disorder across 10 categories. If someone has experienced 2 of the 3 of these symptoms, they're considered to have a mild use disorder for that substance. Moderate, 4 to 5 symptoms, and severe would be 6 or more symptoms. And what you're looking at in that figure 2 on the top right, the pyramid, is that these diagnostic criteria are relatively new. So previous editions of the DSM distinguished between sort of 2 different types of substance use disorder, substance abuse or substance dependence. And the idea is that moving towards a more unified definite, I'm not going to go too much into the details there. That's just something that, as you're studying this more, you're going to see it when you see older papers that are written based off DSM-4 criteria and new DSM-5 criteria. The important thing to remember is that the new DSM-5 criteria decided to rather than separate this into sort of 2 different diagnostic categories, to encompass the symptoms that would both be for abuse or dependence into a singular syndrome or disorder and diagnose with graded severity, right? So rather than saying someone has substance abuse or no dependence or has abuse and dependence criteria, it may be, they have a substance use disorder mild. The idea was this better sort of reflects clinical presentation and sort of how the individual's issues should be graded and treated clinically. So addiction really is a scientific construct. I mean, it's a common word in popular culture, but when we talk about addiction, I think scientifically what we're generally thinking about is a state where an individual exhibits an inability to self-regulate consumption of substances to the point where it's causing significant distress. And then generally you'd see some evidence of some persistent maladaptive patterns of behavior reflecting what would be temporal impulsivity or compulsion in choices. And what I mean by that is the type of choices and behavior where, you'd have an individual who they're swearing up and down to themselves that they're going to go right home from work and they're not going to stop at the bar and drink. And the bar's 3 hours away and home's 4 hours away. And that's fine. They have every intention to do that and they feel they are. But when they're driving by the bar, they just see the sign and they see the open light on and they just feel like they can't help but pull in and go and have some drinks. So that's sort of what we talk about. That's an example of some behaviors that we see when we talk about addiction. So these this compulsion and choice, or this difficulty to self-regulate one's own behavior in the moment that leads to a lot of regret. And this is typically, in terms of the clinical definition of addiction, we don't necessarily use that word clinically, but this would typically be limited to individuals with moderate to high severity of a substance use disorder, or often individuals suffering from physical dependence. So folks who suffer pretty significant withdrawal when they don't use a substance, right? So the desire to avoid withdrawal has happened to take a lot of control over their behavior, and they introduce some of these temporally impulsive or compulsion-like components to their choices. So just to give you guys a brief rundown of the DSM-5 criteria. So again, it's 2 of 11 for a mild, 2 to 3 of 11 for a mild, 4 to 5 for a moderate, and 6 or more of it for a severe substance use disorder. You can see that these criteria are largely focused on, again, problems related to regulating use and impairment in life because of use. So it's not the amount used necessarily, it's using in progressively larger amounts for longer than you meant to or intended. So not necessarily how much of the given drug you're using on a specific day, it's, needing to use more each use day as the weeks persist, and then actually intending only to use X amount of drug one night and then stop and do something else the next day, but having that pattern of behavior persist into the point where it's disrupting your earlier intentions. Things like spending a lot of time trying to acquire and use drugs, persistent cravings or urges to use substances that are disruptive to mental health and emotional well-being, problems at school or work, continuing to use even though it's introducing problems with your family or other interpersonal relationships, etc. So again, this is the clinically focused definition that we're talking about when we're talking about substance use disorder. So just a little bit about risk factors and prevalence, and these are just, again, some general ballpark statistics that I think really are good choices if you want to sort of sum up what you see with progression. So the probability and speed of transitioning from first use to a substance use disorder occurs relatively quickly with opioids and stimulants. So when we showed you those figures earlier from the Candell paper about age of initiation, aging out, that was just showing the prevalence of use, but it wasn't really showing what happens to folks that don't age out and sort of how their trajectory is different. So generally, if folks are going to develop a substance use disorder for a particular substance, it's going to happen within 5 to 7 years of age of first use overall, for the most part. And that's particularly true with stimulants and opioids. The folks tend to develop use disorders more quickly for those. In terms of factors that predict greater vulnerability to developing a substance use disorder, so having a pre-existing mood disorder like depression or anxiety, or histories of especially childhood trauma, post-traumatic stress disorder type symptoms, these conditions are robustly associated with higher rates of transition from first use to substance use disorder. So there's associations at several time points, right? So there are risk factors for the hazard or initiation of use, and then there are risk factors for among individuals who are using, who is going to transition to disordered use versus who is going to continue using at a non-disordered use level or age out. And this is where those effects are really pronounced in terms of having pre-existing mood or anxiety disorders or childhood trauma. It's the transition from first use to developing a use disorder. The other big one is having another pre-existing substance use disorder. Substantially increases the risk of transitioning from use of a new substance to a disordered use of said substance. So, for example, an individual who has a prior use disorder for a non-opioid substance happens to use opioids for the first time, they are 4 to 6-fold more likely to develop an opioid use disorder than a first-time user of opioids first-time user of opioids who does not have a pre-existing substance use disorder for just different substance. Earlier age of onset is another big variable here. And this is consistent across all substances and across almost all metrics of substance-related outcomes. So probability of transitioning from use to having a substance use disorder, the intensity of use, how disruptive the use is on that individual's life course and their social and occupational functioning, how likely they are to succeed in treatment is decreased if they started using younger. So pretty much across the board, across all substances and all metrics of progression, severity, relapse, earlier age of onset is generally associated with worse outcomes. For some substances, particularly methamphetamine and other stimulants, sexual gender minorities generally experience higher rates of substance use disorder, are more likely to develop substance use disorders or substance use related problems. And overall, relapse is a persistent phenomenon within all substance use disorders. So relapse would be defined, it's tough actually to define it fully operationally in the field, but generally it's defined as resumption of use at a problematic level after a sustained period of abstinence, right? So someone is using in a hazardous or disordered way, is able to achieve a period of abstinence and then starts using again, and that use progresses to a level where it once again would be disordered or hazardous. So that's a very common phenomenon in both naturalistic or untreated remissions, so individuals who will quit spontaneously or without any sort of professional intervention, and after successful treatment. So even with our really effective treatments, somewhere about half of individuals tend to relapse within 1 year of completing treatment. And this is true across different treatment types. So treatments of varying levels of effectiveness are generally quantified as such because of their ability to produce abstinence during treatment. But so if you have a more effective treatment, your ultimate outcome is going to be better because you're getting more people to quit, and then if half of them relapse, the remaining number non-relapse is higher than would be for a less effective treatment. But across all treatment types, especially once treatment is withdrawn, relapse unfortunately happens about half of the time. So I'm just going to talk about a little bit more natural history data. As I said in the intro, I was going to talk a little bit how this breaks up by sociodemographic characteristics. This is a split by gender and race and ethnicity, and isn't a full natural history study, but it's looking at a span of individuals across the life course. This is sort of a quasi-natural history type study. So rather than following one cohort of individuals from age 18 to age 90, I mean, that'd be a 72-year research study, but they're just sampling from these different age groups and just looking at the patterns to shine some more light on these relations. So what we're seeing here in these figures is for alcohol, tobacco, opioid, and cannabis in clockwise order there. We're seeing the estimated proportion of individuals in this sample who are meeting criteria for substance use disorder across the ages of the sample. So what we're seeing here is, and then we're seeing in the dotted line, we're seeing males in the solid line. This is for female participants. And the slightly finer lines around each trend line represents the 95% confidence interval. So what we're seeing here is that for males overall are more likely to meet criteria for substance use disorders across these 4 substances than females. But this trend is most robust at younger ages across all substances. So it's that generally it's younger men that have the highest rates of meeting criteria for disordered use of sort of these 4 common substances of abuse. And this is looking at the data only in the same 4 categories in the same way, only instead of being split by gender, we're splitting by race and ethnicity. So they're splitting by white, Black, and Hispanic Latino, which is interesting because it's not entirely the NIH definition of separating race and ethnicity. They're collecting white Hispanics and just calling them Latino in this group. But what we see here again is that we generally see higher rates for 3 of the substances among white men, and generally difference is really pronounced at younger ages, so individuals in their mid-20s. The only sort of outlier there is that we're seeing that for cannabis use disorder, you have higher rates of probability of meeting criteria for cannabis use disorder among African Americans than you do among white individuals. The opioid use disorder figure here, I think, is really interesting because what you're seeing is a really interesting trend in prevalence by age as a function of race ethnicity. You're seeing, what would typically be your earlier peak in use and disordered use of opioids in white individuals, but Latino individuals, you're actually seeing a peak at a much older age. Now, they didn't go too much into some potential reasons for this, but it opens up some pretty interesting questions. So I thought this would be a good opportunity to share some data from a natural history study that I did while I was in grad school, mostly because part of the purpose of this lecture series is to start giving you guys some information about grad school, not only the application process, but sort of like, what is it like to be a grad student? How do you think? And how do you get involved in different scientific projects? So this was a paper we ended up doing. This was one of those cases where this project was a function of having another project that didn't go well. Well, it's not that it didn't go well. It's that this study was inspired by a prior study that had unexplainable findings based on the literature. So this was a study we did looking at the timing of changes in smoking in pregnant women during early pregnancy, sort of characterizing the natural history of changes women that are smoking when they learn of their pregnancy will make between the time they learn of their pregnancy and their first prenatal care visit. So their first medical contact. And the rationale for doing this was actually, so the first project I was working on as a grad student was a study looking at characterizing nicotine withdrawal in pregnant smokers. So the idea there is that, about 20% of women of childbearing age, well, now it's down to about 18% of women of childbearing age will smoke. And the vast majority of them will continue smoking throughout their pregnancy despite substantial desire and intentions to quit and a lot of quit attempts. About half of them will reduce their smoking by about 50% or more, but aren't able to quit. And the reason why we did this study was that, so during pregnancy, a lot of medications are Schedule C, so they're not recommended. So the most effective smoking cessation treatments, things like varenicline, nicotine patch, et cetera. There wasn't really enough known about treatment response in pregnant women to recommend using them. And one of the ideas here is that in order to effectively use an agonist-based treatment for nicotine dependence, you want to make sure that you're suppressing what are nicotine withdrawal symptoms. The issue here is that a lot of symptoms of nicotine withdrawal are also effects of pregnancy. So things like irritability, increased appetite, et cetera. So this was a study that was done to sort of characterize the withdrawal symptom in abstinent pregnant smokers in order to collect some data to inform how to use medications in this group to treat nicotine withdrawal. Because you wouldn't want to give someone medications to treat a symptom of pregnancy, so potentially exposing a neonate to a medication that isn't needed because they're not actually experiencing what is nicotine withdrawal. They're just normal symptoms of pregnancy. So for this study, we looked at data from pregnant smokers who were enrolled in a different behavioral treatment for smoking cessation. And we ran sort of two control cohorts, a group of non-pregnant smokers and pregnant non-smokers. These are withdrawal data collected during a quit attempt at baseline and then over 2 weeks of abstinence, which is broken up into 8 visits. And what we saw here was that the pregnant smokers had sort of this elevated baseline average withdrawal score. So what an average withdrawal score is basically a mean sum score of a set of validated symptoms. So things like increased appetite, irritability, craving for cigarettes, etc. And we didn't really know how to explain this because this was a baseline taken before these individuals had quit smoking. So they're not necessarily showing, if you look at the group in the squares, the non-pregnant smokers, you're seeing that their symptomatology peaks on day 2 during early abstinence, as you expect. So this group isn't really showing withdrawal. It's not going up during abstinence, but it had this elevated withdrawal score at baseline, and trying to figure out why that was. And my advisor's like, oh, look at the literature. Let's see, what does the literature say? And so really all that was out there at the time was what was known as relations about smoking prior to pregnancy and on the day of the first prenatal care visit. So no one had ever really examined the day-to-day changes that the women make during early smoking. And all that was really out there in the literature is that, about 20% of women will quit. And those women who were successfully quit at their first prenatal care visit smoked an average of about 10 cigarettes a day before they were pregnant. And then the remaining group that continued to smoke would reduce by about 45%, and this group generally smoked more, right? So classifying based on smoking status at first prenatal care visit, we know a couple of things about what they did pre-pregnancy, but nothing about what they did, the natural history of what they did during that 5-week time period. So there were data available to do this. So it turns out for these trials on this behavioral intervention for promoting smoking abstinence during pregnancy enrolled, two different types of participants. Pregnant women who were still smoking who wanted to quit, and for pregnant women who had, at least during their early pregnancy, quit and wanted some support to prevent themselves from relapsing to smoking. They knew they're at risk and they wanted to stay quit. So what we did was we had classified this group based on smoking status at first prenatal care visit. And we either called them abstainers, so those who had quit with no smoking for the past 7 days. And then we split the continued smokers into sort of 2 groups. We called one group reducers. So those who had made greater than 50% reduction from pre-pregnancy, and the basis here is that in the literature, reducing your smoking by at least 50% is considered a clinically significant reduction in smoking. And then maintainers, so those who have less than a 50% reduction or reported no change. We use timeline fallback to examine the history of these changes. That's essentially just having people walk through a calendar and fill out their smoking, the number of cigarettes they smoked each day at each point in time on the calendar. And what we learned was that the vast majority of women who made these changes made them extremely early in pregnancy. So on average, if you were going to quit smoking as a function of learning of pregnancy, you're going to quit within 2 or 3 days. If you were going to make any significant reductions, you were going to make those changes within 2 or 3 days. And then largely the rate of change you made was going to level off. Conversely, if you weren't going to make any changes, you weren't going to make early changes and they weren't going to bump back up. So you really know a lot about how much someone is going to change their smoking as a result of their pregnancy by the changes they make within the first couple of days. So this has some implications in informing how clinicians triage smoking if recommending treatment. This has implications in deciding whether or not to use medication at the time of their first prenatal care visit. Like that elevated baseline symptoms, those aren't symptoms of nicotine withdrawal because these folks have already made these changes in their smoking, and their smoking rate has been stabilized for largely 4 or 5 weeks, right? So that's why we do natural history studies. I'm going to skip the rest of this because I'm running over on time, and I want to get on, let Minnjuan go ahead.
You did not have to cut your time short because a lot of what you have shared is going to lead very nicely into what I hope to share with you all today. So I want to ensure that everyone can hear me well. And I am trying to figure out how to share my screen. Can you guys see what I see? Can you guys see the presentation?
No, not yet.
Okay. Go one more time. Give me just a moment. Don't know what's happening here. How about now?
Yep.
Perfect. Fantastic. So just to give you a little bit of background on me, I am Minnjuan Floyd, and I actually sit in DESPER, which is the Division of Epidemiology Services and Prevention Research. I am not an epidemiologist. I actually sit in the Services Research branch, but prior to my coming to NIDA, I spent about 5 years at SAMHSA. The first 3 years I spent working with data directly in the Center for Behavioral Health Statistics and Quality. And then I moved to the Center for Substance Abuse Treatment, where I dealt again strictly with the data across all of the programs that came from the center. I have a PhD in Health Services Policy and Management. And at NIDA, I am the HIV and infectious diseases lead in our branch. So you might be wondering why I am talking about epidemiology when services seems to be my jam. We have to know what the data says in order to know where treatment should be focused in the field. So while it's not my educational background, it is definitely an area I had to become very comfortable with and very quickly acclimated to in my work. So I have a poll. It's not going to be a Zoom poll, but I wanted to know from you, and you can feel free to come off of mute to answer if you so choose. What are the most used psychoactive substances in the United States? And I'm going to pause here to see if any one of you or any couple of you want to jump in and provide your responses.
Yeah, I think it's methamphetamines.
Meth, okay, is a stimulant, okay. Any other thoughts?
Yeah, heroin and cocaine.
Okay, stimulants, okay. Opioids. Other thoughts? Let me get, is something going on in the chat? Am I seeing things in the chat? Alcohol, LSD, okay. I see, what do we have here? I'm trying to advance, sorry guys. What do you think? Caffeine, yeah. Yeah. A lot of times we don't think about tobacco and alcohol as often as substances, but they fall under the categories as psychoactive substances. So when we talk about some of the substances that I'll talk about as we move forward in the presentation, just keep these in mind. So just to give you a little bit of a definition of what epidemiology is, it's the study of the distribution and determinants of diseases in human populations. And obviously I'll be focusing on substances here. I will not be talking about infectious disease, but I will talk a little bit about co-occurring mental health disorders, et cetera, that we often see with substance use. Our studies in EPI are concerned with the extent and the types of illnesses and groups of people and those factors that influence their distribution. So what is causing a change in disease prevalence? And, you know, when we look at initiation or incidence, what might be those risk factors that are affecting first use in our world of substance use? Um, and specifically, epidemiologic data sources track those patterns of drug use, drug abuse, and the consequences for several decades. So when I think about resources or data sources, I'm talking about NISDA, which you may have heard of, which is the National Survey on Drug Use and Health. And SAMHSA sponsors that particular very large scale survey, as well as the TEDS, that is the treatment episode data set. Monitoring the Future, which comes out of my colleague's branch, the EPI branch here in DESPER. And that focuses on collecting data from youth beginning in 8th grade through 12th grade. So we get a sense of what's going on with the youth in the United States and their thoughts and practices when it comes to substance use. We have the DAWN, the Drug Abuse Warning System, which is also at SAMHSA, the National Drug Early Warning System, which is at NIDA, and the National Epidemiologic Survey on Alcohol and Related Conditions, which is at, I believe, NIAAA. I will focus most of my talk on data based on NISDA because I believe NISDA gives us a really great sense of what is going on with people ages 12 through adulthood who are non-institutionalized, et cetera, et cetera. And I won't give too much of a background on NISDA because I could talk for days and hours about that. But just to give you a sense, it really does collect data from folks ages 12 and up. I talked a little bit about the EPI research branch, but their goal is to promote research that examines the impact of all of these levels of risk and protective factors related to substance use, abuse, and addiction. And their findings inform what my colleagues do in the prevention research branch, and of course in my branch, in the services research branch, to reduce the burden of substance use, abuse, and the addiction on the nation's public health. So I wanted to start a little bit and talk about substance use prevalence rates. And this is based on 2019 data, I'm sorry. Among persons ages 12 and older, and you'll often see me reference 12 and older because again, this is NISDA data. 60%, a little over 60% of people used a substance in the past month. So that's a nice proxy for current use. That's more than half of the nation. If you are 12 and older, you've used some kind of substance. So we're talking about alcohol. More than half of people drank alcohol in the past month, and 21%, give or take, used some kind of tobacco product, whether that's smoking, chewing, etc., in the past month. And then 13% used an illicit drug in the past month. So that is what we begin basing our watchful eye on how we intervene in treatment and services research. Here, I wanted to give you just the sample of what we look at when we see changes of use, changes of rates. And this is particularly highlighting illicit drug use. And what we want to do is pay special attention to marijuana, meth, opioids especially. And what do you think is happening in the nation in general while we're seeing a significant increase in marijuana use? Any ideas as to what is happening across the nation as to why we're seeing more use? Yes, legalization and decriminalization, absolutely. And, you know, we have to remember that marijuana, while it is legal in many states, it is not technically legal across the nation. So we still collect data on use in our federal surveys. So just to give you some comparison between 2008 2019 regarding substance use. This is not substance use disorder yet. We'll come to that in just a couple of moments. But past month marijuana use and past year daily use or almost daily marijuana use significantly increased in adults ages 26 and over. Past year marijuana use disorder significantly increased in adolescents. There was no change in cocaine use across all groups, and there's an upward trend in meth use in adults ages 26 and older. And that increase we began to see that increase in 2016, 2017-ish. And more along the lines of stimulant use, we started seeing a downward trend in prescription stimulant misuse and those ages 18 to 25 years old. So that is a critical age group, and you'll see me talk a little bit more about that a little further in the presentation. Uh-oh. So let's talk a little bit about substance use disorder prevalence rates. And this is, again, 2019 data. And we're talking about folks that are 12 and older. We saw an increase in marijuana use. There's no surprise there. But we did see a decrease in prescription pain relievers from 2015 to 2019. And for that older, younger adult population, I'll call it, we did see an increase in past year marijuana users from 2002 to 2019. Now, I want to ask you, what do you think might be happening as to why we're seeing a decrease in prescription pain relievers, reliever use, rather, from 2015 to 2019? What do you think might be happening there? Any ideas? It's been a long time since I taught undergrad, so I'm going to ask you a lot of questions. Let's see. I see some things in the chat. More restrictions on medication, absolutely. More people using marijuana instead, absolutely. Yes, 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 all true. Remember, more regulation. Physicians are trying to not immediately prescribe pain relievers, and there is an embrace of alternative methods to treat pain, and there's more regulation, and physicians and clinicians are trying to implement pain management plans that don't include or include some kind of treatment, or making certain that they're weaning patients properly off of prescription painkillers. So these are all spot on answers. More people are using marijuana instead to address their symptoms related to pain. Absolutely, fantastic answers. So here is just one example of tons of graphs that I can show you, but I wanted to draw your attention to marijuana use among that older young adult beginning population. And we're seeing some significant increases from 2018 to 2019. If you look at past month use, you'll see an increase from 18.5 million to 22 million users. And that is definitely statistically significant and probably clinically significant as well. And you'll see the same kind of trend in past year daily or almost daily use from 2018 to 2019, from 5.9 million folks to 7.3 million folks. So again, some of the responses that you all came up with are what we are seeing and finding in the field as to why there might be this increase in marijuana use. And let's kind of jump right into substance use disorders. We saw a little bit of stability with past year substance use disorder between 2015 and 2019. So no increase, no real decreases. These are statistically speaking numbers between 2015 and 2019. And what we saw in persons, again, above age 12, regarding substance use disorder is that 71%, give or take, had a past year alcohol use disorder. and about 40% had a past year illicit drug use disorder, and 11.8 had both an alcohol use disorder and an illicit drug use disorder in the past year. And that begins to point to polysubstance use. So let's back up and talk a little bit about opioid misuse and what we're seeing between 2018 and 2019. I mentioned this a little bit earlier. We are seeing some leveling off when looking at the 26 and older population, as well as generally speaking 12 and older. But there's something happening that we like to see in the 12 to 17 population and the 18 to 25 population. We're actually seeing a decrease, which is phenomenal. This is what we want to see. We want to know that people are either not engaging or they're seeking treatment, and the idea of opioid use or pain relief, etc., is being addressed in services, treatment, and even in preventive measures that are being taken. Specifically in prescription pain reliever misuse, what we're seeing is in the 12 to 17 as well as 18 to 25 categories, a significant decrease, a statistically significant decrease in what we're seeing in misuse, and from 2018 to 2019. And we're seeing some leveling off in older adults, those that are 26 and older. So again, no net gains or losses for older adults, but we're really seeing what we want to see in younger children, adolescents, etc., and young adults. Let's progress to opioid use disorder. We're seeing some encouraging trends. We are seeing reduction in opioid use disorder from 2018 and 2019, especially. This is what I love to see as someone who focuses in treatment research. Something is working. Something is working in the field, and we like to see it, and we want to know now what works good, better, and best for the field. So these numbers are encouraging again across all age groups. We're seeing all statistically significant reduction, as well as I'm certain we're seeing clinically significant reductions in OUD as well. So just to highlight those last couple of slides, we're seeing significant decreases pretty much across the board, if not leveling off, definitely some decrease. And despite these gains, we are still seeing opioid overdose deaths. They're increasing. And we want to know that what is going on with synthetic opioids and the need, and we know that there's a need to continually engage people in treatment and recovery services. And I want to underscore the importance of recovery services as well, because I feel like they don't often get enough shine, but recovery is definitely possible. If persons enter recovery, we hope for them to be in long-term recovery, and we hope that the treatment services that they receive are, again, of the good, better, and best. We want them to have the best treatment services that will yield the best outcomes, and for them to be living lives in long-term recovery. Polysubstance use is actually an area that Evan touched on a little bit earlier, so I won't go into a lot of detail here, but we do know that polysubstance use is common. If a person is having problems with one substance, we know that it is very highly likely that they could be having problems with other substances as well. And treatment providers, again, my jam, must screen for and treat all substance use disorders and problem substance use. So again, not waiting until there is an actual or diagnosed substance use disorder, but if we see problem substance use, or we see persons engaging in those risky behaviors that could lead to problem substance use, we want to intervene as early as possible, especially on the prevention side. It's much easier to address on the prevention side than it is on the treatment side. So earlier I mentioned that we talk a little bit about co-occurring substance use disorder and mental illness. And here we're seeing increases for the most part across the board, except for when folks get a little bit older, we're seeing some leveling off, especially between 2018 and 2019. And I'll talk a little bit about that in greater detail in just a few moments. I also wanted to show you substance use and mental illness among adults. And again, same trend, we're seeing increase in, we're seeing folks with uh, serious mental illness and any mental illness across illicit drugs in general, marijuana, opioid use, misuse, and alcohol, binge alcohol drinking, and cigarette use. We're seeing this increase in mental illness. So that tells us in the treatment field that we have got to treat substance use and mental disorders together when we can. There's a large gap in those treatment needs, as the data demonstrates. Those who don't get treatment really have higher risk of falling deeper into the areas of more difficult time treating substance use disorders, substance use, as well as mental illness. So we again encourage best practices in treatment of substance use disorder as well as mental health as well. I think that's the end. I kind of ran through everything because I wanted to make sure that I saved space and time for questions. I don't know if we have time for questions. We're already at 4:01, and I do want to be respectful of your time. I'm happy to take questions if there are questions that you have, and I'll stay on. I guess that Evan would be amenable to questions as well.
Absolutely. Yeah. That was excellent. Thank you.
I know you guys are not a shy bunch.
I'm looking at the chat box too, if you prefer to put them in writing.
Sure. So you guys mean to tell me we answered all of your questions in an hour about the natural history of substance use disorder and epi? Certainly not.
It is 4:02 though, so.
Yeah. I'll put my email address in the chat. So if you have is it possible that the decrease in opioid prevalence as groups increase? Hold on, I can't see the whole question. Increase in age due to fatalities relates to long-term use. Potentially.
That may be a small contributor to it, but I don't think that's the entire cause of that decrease in prevalence, right? So across all drug classes, folks will age out and you'll get cessation use. Substance misuse and substance use disorder. Oh, sorry, another question. Yeah, so let me finish the first one. Yeah, so folks age out, and yeah, some of it would be sort of fatalities. Yeah, that's true. Yeah, misuse and substance use disorder. Okay, so misuse is pretty much any non-medical use, right? So if you are, or use beyond what would be normal recommendations of low risk use. So like drinking to intoxication would be described as alcohol misuse, right? Using medications that aren't prescribed to you either for recreational reasons or even for functional reasons. For example, using someone's ADHD medication that's not prescribed to you to study. So you got it from a friend, that would be classified as misuse. A substance use disorder is when that use is, again, causing significant negative interpersonal and interpersonal problems, right? So use disorder is defined by the impact of that misuse on broader, more global functioning of the individual. Does the increasing prevalence in mental illness indicate an actual, we say physical increase, we mean an actual increase in the rate or an increase in reporting? Very difficult to say, not my area of expertise. I would say that historically, in past decades, a lot of mental illnesses were underdiagnosed or weren't recognized. So I think some of it's, yeah, increase in recognition and diagnosis and reporting is probably the most of it. Again, not my area of expertise.
I I would agree with that. I think that's spot on. We can recognize disorders in a little more educated way these days. I see a question about the data and what it looks like when it comes to vaping, e-cigarettes, etc. Now that they're trending, absolutely. I just did not include that data. Monitoring the future has incredible information on what those trends look like, especially in younger populations. And there is more data in the NISDA report from 2019. That's the most recently complete data that we have nationally as well. I don't have that data immediately on hand, but I can guarantee you that we're seeing increases in both.
I think I actually have a slide
Do you?
vaping for I can probably pull up. Yeah.
Awesome. I see another question about do the statistics stay the same across people from different countries? That is a great question. I don't have that data immediately available, but I can tell you that there are differences, across countries. Honestly, it depends on the country and really what is more readily available or more, I'm trying to think of a way to say this. And I actually have a large international portfolio. So just depending upon the country is what I'm seeing an increase in research in response to those challenges. So it's not necessarily the same here in the US as it is in Vietnam, in Ukraine, in Kenya, etc.
So you guys seeing this slide on smoking and vaping for cigarettes and cannabis? Is that yeah, so if this answers your question, what we've seen really since the mid-90s is a pretty precipitous and steady decline in combustible tobacco use. This is current use or past month use, I believe. And then a relatively level cannabis use, but somewhat of an increase. Then we look at the onset of vaping for both. We see that really the most pronounced change is that vaping nicotine is far surpassed combustible cigarette use in terms of primary nicotine use. So in terms of relative to peak smoking 20 or 30 years ago, overall prevalence of nicotine use across smoking and vaping hasn't gone down that much, but it's really the prevalence of combustible use that has dramatically decreased. And then in terms of just overall proportion nicotine use, that decrease is offset in part by vaping. But I think we're learning that these behaviors have different health risks associated with them. So when we're just talking in general about nicotine use, we see vaporizing has surpassed combustible use in at least adolescents.
I had a quick question, if I could ask. So both, thank you for your presentations, but Evan, I'm working in a lab this summer that's working with maternal e-cigarette, tobacco, and cannabis use. And so I was just wondering if I'd be able to have a copy of the slides just to look through the commentary that you had, just to learn more about it.
Yeah, sure. I've got, so that's my area. I do a lot with tobacco and cannabis. Tobacco mostly at NIDA, but historically I was a cannabis researcher before I joined. So yeah, shoot me an email and remind me, and I could probably send you a couple of decks.
Okay, thank you so much.
Okay.
So this is more of a question for Evan. Yeah, I'm aware that the earlier age onset for using a substance increases your likelihood for substance use disorder by a lot.
Yep.
And that makes sense for, adolescents or people, under the age of 20, but does that still stay the same for someone that's maybe like 30 or 40, and then you compare it to someone way older, like 50 or 60?
So it's very rare in most cases. Well, I mean, in certain sets of cases, you will get substance use disorders where you have a later onset of first use. With the opioid epidemic and the prescription of pain medications, that was a case and happened, but overall for the development of disorders on drugs that are not used medically, right? So cocaine, well, I mean, technically it is used medically for throat surgery as an anesthetic, but it's not used medically commonly. Cocaine, methamphetamine, alcohol, cannabis is used medically now or medicinally. So actually scratch that one, but drugs not used medically, it's very, very rare for someone who starts using above the age of 25 to develop a substance use disorder. Again, if it's something like opioids where it starts as medical use and someone develops perhaps physical dependence and withdrawal as a primary symptom before they develop like a pattern of irresponsible or misuse recreationally, then it happens. But yeah, it's really age of onset, and it's not clear if that's causal or if that's just that early age of onset of substance use happens to be a proxy for a constellation of risk factors for substance use disorders. So the folks that are more likely to start earlier are more likely to have maybe other issues that are going to make them more prone to developing problems. So it just ends up creating, you know, a perfect storm of risk factors. But again, we can't demonstrate for certain that all these things are causal, right? So is it that it's been really tough to untangle, you know, is it, you know, pre-existing depression or mood disorders that leads to problematic substance use and substance use disorder, or is it the substance use disorder that leads to the persistence or worsening of the mood disorders? And that's why they're both expressed comorbidly in someone by the time they reach their mid to late 20s. We've done a lot to look at examining these causal relations. So taking what we've learned from these natural history studies and doing experimental work, even preclinically in animals, you know, testing the effects of adolescent exposure to nicotine on subsequent use of and resistance to extinction of responding for cocaine infusions, or, you know, resistance to punishment suppression of cocaine infusion, et cetera. So there's been all this natural history stuff. That's why I want you guys to understand why it's important, is this is how the very experimental preclinical models that we use to test these things and the models we use to test new medications are inspired by, you know, what we observe in the real world, trying to model that in the lab under controlled conditions. So we can learn something about it. So yeah, it's a very long answer to your question, but yeah, age of first use is robustly important across everything.
Thank you.
Yeah, I had a question. What do you think factors into such early age when using illicit substances?
I mean, what would you consider an early age of onset in terms of folks who tend to be most vulnerable for problems? It's late childhood or early teens. What factors into it? I mean, I think it's a lot of things. I think it's environmental differences. It's
Peer pressure.
underlying mental health comorbidities. It's access. It's, you know, there's some genetic components involved too. It's a very, very complicated question. And it really is a question of what is the total array of influences and how do they interact versus which one is the most important or which one is causing the other one. So it's one of those things that the deeper you get into it, the more you learn about it, the less you really understand it, because you realize the less that we understand about it.
It generates more questions. It really just does.
Okay, okay, thank you.
It looks like the questions have slowed down a bit.
Yeah.
But if you guys think of more questions, you have my email address in the chat. Feel free to take that down. I welcome your questions. Evan, thank you for having me.
Yeah, thank you. Thank you very much for helping out today. It was a great lecture. I'm glad I had someone to share it with me. I didn't really want to talk for a whole hour, and you did awesome. So thank you. Yeah.
No problem.
All right, I'm gonna go ahead and try to stop recording now. Thanks again. You guys did awesome.
Thank you. Bye, guys.
Bye.
Have a good summer.